Welcome, everybody, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for the last day of September of 2021. Today's CME activity code is 483327. As usual, we have nothing to disclose, and the patient in this case has been de-identified. These are always recorded, and they're available on our YouTube channel, usually within the week. Please subscribe to our channel, and if anybody listening today or knows anybody that wants to be on our mailing list, send myself or Dr. Baxi an email. We'll make sure to get you on the mailing list. And invite all your friends and colleagues and family and pets. We want to get our numbers up. We've got a great case today. And with that, I think Dr. Whittier, it's your case, and you could start by presenting the protocol for us.
Yeah, sure. Thanks, Roger. You can hear me okay, right, guys? Okay, the patient we have today, she's 47, a Hispanic woman. And until now, her past medical history had really been plagued by thromboembolism. She had a DVT and a PE in pregnancy 20 years ago. And she also had this history of obesity that had been a little bit worse over the last 10 years. But she came into our hospital with the acute onset of dyspnea and chest pain. At that time, she was found by CAT scan to have acute bilateral PEs, significant right heart strain. She was very sick. Elevated troponins, and she was admitted for anticoagulation to the ICU. Unfortunately, despite anticoagulation, her symptoms weren't really improving, and repeat imaging also showed no improvement or resolution in her thrombus burden. So she was taken for catheter-directed fibrinolysis, and actually it worked. I've seen some cases where it doesn't, but this one worked well, and she had resolution of her strain on repeat imaging and also of her symptoms. So this was a nice success story of a significant severe PE that actually was resolved. During the workup of her admission for her thromboembolic situation, she had an ANA and a double-stranded DNA checked, and they were both positive. Rheumatology came by and diagnosed her with lupus. On the way out the door, they checked a urinalysis, and it had hematuria and proteinuria. And she was home by the time the PC resulted at 15 grams. So her oxygenation improved, she was feeling better, and she was discharged on anticoagulation. The rheumatologist called me directly and said, hey, I've got this person who was just put on anticoagulation that has new onset 15 grams in lupus, and get them in for a biopsy, please. So that was I was like thinking, why wouldn't they have just kept her? But that's how things go. So I saw her quickly in follow-up. Actually on a video visit. And at the time, she fortunately had denied any symptoms. All of her chest pain and shortness of breath had been resolved. She had no symptoms of joint pain, serositis, no history of alopecia or ulcers, dry eyes, dry mouth, any malar rash. But she did have leg swelling still that was persisting, as well as frothy urine. So her past medical history really, again, was plagued by thromboembolism with 3 spontaneous abortions in the past, plus the DVT-PE in pregnancy. Her hypocoagulable workup was done by hematology, which included the entire gamut of what they knew in 2000, including factor V Leiden and beta-2 glycoprotein 1 and all of the lupus anticoagulants. And it was repeated in 2021 with a couple additional tests, and they were both negative for a hypercoagulable syndrome. Surgical history is really sort of irrelevant. Social history, never drinker or smoker, and no illicit drugs. And she didn't have any autoimmune disease or kidney disease in her family. Her medications were Lasix, metolazone, lisinopril, and iron, and she was on Eliquis twice a day. She had not been started on any immunosuppression by rheumatology yet. Unfortunately, when I saw her, she also had normal renal function. So on exam, she was afebrile, blood pressure was 129/78. Her weight was 240 pounds and height 5'4". She was 98% on room air, and she was really pretty comfortable. And the only thing that really plagued her now was a 3+ lower extremity edema. And again, no rash or synovitis. So 9 months ago, before her admission for the PE, she had a normal serum albumin at 4.1. 3 months ago, her albumin was 3.0. Okay, the only urine studies besides this 15 grams that was on admission was from 2017. So 4 or 5 years ago, she had normal urinalysis with no blood and no protein. She also had an ANA checked in 2005. that was 1 to 320 in a nucleolar pattern. Okay, and then the current admission labs showed that her K was 3.7, chloride was 106, bicarb was 20, renal function was normal, her albumin 2.5, her LFTs were unremarkable, her total cholesterol 349, triglycerides 478, and HDL was 48 and LDL was 200. Her CBC had a white count of 12.6, and again, she did not have any steroids. Hemoglobin was 12.5, and her platelets were 165. Complements were normal. Her ANA was 1 to 320, and her double-stranded DNA was 32. Her Smith, SSA, SSB, and rheumatoid factor were negative. Other serologic evaluation, COVID, HIV, hepatitis B were all negative. And again, like I said, her hypercoagulable workup was negative in the past and negative again. Her urinalysis was really significant for the 2+ blood and inactive sediment, along with 15.4 grams of protein. I didn't have an ultrasound, but I did have a CT scan, what they showed of her kidneys during her workup for her PE, and it showed that both kidneys were normal in size without hydronephrosis, and they were able to see that there was no renal vein thrombosis as well. And so we set her up for a percutaneous renal biopsy.
Bill, was she on Eliquis at the time that they did the biopsy, or how did you plan that?
Yeah, that was a little tough. I had to check in with hematology. Interventional radiology, fortunately, was happy with doing this CT guided for 1 day off of Eliquis. And so that's what they did. And then they restarted her back up on Eliquis the next day. Sometimes I've had to use if we really need to hold it for a while, sometimes we've had to put in a filter in the meantime to make sure that there's no active PE or something during the time, but they hematology and interventional radiology thought that we didn't need to go that route.
It's really interesting because that's a common, conundrum we get into, and I'm sure there's many permutations, and it depends on how heme feels, how long it's been out, what the indication was. Is it a fib? Is it a pulmonary embolus? Is it a DVT? I mean, she had a life-threatening disease, but that was 20 years ago that she had the emboli, or?
Well, no, I mean, she currently presented with this one that they had to do fibrinolysis to. So yeah, she
that
had
was
that
recently,
20 years
okay.
ago, but right now she was 3 weeks into her repeat anticoagulation.
So she had a PE 22 years ago. Was she on anticoagulation for 22 years, or?
No, she had a DVT and PE in 1999, and she had her spontaneous abortions. She was anticoagulated during her pregnancies, and then she was anticoagulated for about a year after them. And for the last 15, maybe 17 years, she had not been on anticoagulation.
And then now she presents again with a PE, thrombolysis, and what looks like nephrotic range proteinuria.
That's right. And before that time in 1999, or at least prior to 2017, there was no proteinuria.
Great. Anybody else have any other questions?
I saw something in the chat about COVID vaccines, and she was vaccinated. Yes, it was. When did she get it? It was probably about 4 months prior to her presentation, her current presentation.
That's a excellent question. Excellent question. Good. I would like Dr. Rubin to give us our first crack at this case. Mario, you want to walk us through your thoughts?
Sure. Thank you for the opportunity. For the residents, upcoming fellows, this lady certainly has nephrotic syndrome. And my idol and former mentor, George Schreiner, defined nephrotic syndrome as the constellation of 3.5 grams of protein in the urine in the setting of a normal kidney function, hyperlipidemia, edema, and hypoalbuminemia. Some people have added lipiduria to that definition, which you may or may not find in the form of oval fat bodies, waxy cast, and the like. I had a discussion with another great mentor who is not present today, Dr. Glassock, following my last statement at this conference, where he says he couldn't find the statement by George Schreiner of normal kidney function, and he even sent me the original American Journal of Medicine report. But having been a fellow of George Schreiner, that's what we were pounded over and over again. At any rate, So the way I approach nephrotic syndrome, the connotation is that the patient has a glomerular disease, is into a primary or a secondary glomerular disease. Some of you may say, wait a minute, there is also hematuria. Is this a combined nephrotic nephritic? Well, she's not hypertensive. I don't know what these red cells look like, were they suggestive of glomerular hematuria by being dysmorphic or not, I don't know. And above all, she is on Eliquis when this urinalysis is done. And we have learned from recent as well as other reports that both the Coumadin and direct oral anticoagulants can trigger hematuria. And of note, it appears that the entity of acute kidney injury due to anticoagulants is much less with direct oral anticoagulants as a side issue. In turn, I mean, this lady has other components in her history which suggest that she has a secondary glomerular disease. I mean, and it reads lupus any which way you go. She has a history of a hypercoagulable state. 20 years ago, they did not identify the cause. I mean, but then she was not nephrotic, or at least we weren't told that. So I suppose I would have repeated it again, just to make sure 20 years later that there is no issue. The fact that she has had spontaneous abortions times 3 suggests that this is associated with lupus, and I will be interested in repeating again the lupus anticoagulant as well as the antiphospholipid antibodies. Now, in terms of serology, she switches. She has a nucleolar pattern, which is antibodies directed against extractable nuclear antigen, and mainly seen in lupus as well as scleroderma. This is certainly not consistent, this picture that we were told with scleroderma. And then she has a homogeneous pattern, which is primarily seen with lupus. Positive anti-double-stranded DNA and normal complement levels. Can you have lupus nephritis in the setting of complement levels which are normal? Yes. Now, in terms of lupus nephritis, do we think she's got a class 3 or class 4? You know, I don't think so. Her renal function has remained stable, and she has massive proteinuria, and therefore class 5 or membranous lupus is will be #1 on my list. We know from the work at Mayo that the determination of exostosin 1 and 2 antibodies is helpful, as well as the staining of the antigens on biopsy. We'll get to it when we see the histology, which will help in the diagnosis of this entity. But again, it's not widely available. What else could this be? You know, in terms of a primary glomerular disease with lupus as a side, well, we deal with the splitter and lumping, and we had enough of that with Dr. Rodby and Glassov recently. So I'm not going to dwell into that. I mean, the explosive nature of this entity, could this be minimal change? Sure. Could it be focal sclerosis? Sure. Could this be primary membranous? Sure. Membranoproliferative, I don't think so, because the complement levels are normal. So short of that, I am afraid I have run out of a discussion. My #1 diagnosis would be a class 5 lupus.
So the argument always kind of comes up about lupus and how do you diagnose lupus and how many criteria you need to have for lupus. And I mean, basically, she has what, a PE with a negative antiphospholipid antibodies and some serology. How convinced are you that she has lupus?
Very convinced.
Based on?
Based on my own personal experience, I've seen patients like this, Hispanic, rises, the red lights go on. Here in Texas, in the Valley area, you're Hispanic and have this clinical picture, you have lupus till proven otherwise, and usually they have lupus. The history of abortion also suggests the possibility of lupus, and serology goes along with it. And I know that your point is right on the money in terms of the criteria utilized for lupus, but that will be my impression. There is another entity which is to be considered in Hispanics, which can present with significant proteinuria, but is usually a tubulointerstitial process, and that is led to amyloidosis. I don't know what the albumin to creatinine ratio is here and see if there is a gap, but I suspect that it was high, and there is a mixed glomerular and tubular proteinuria here. The other thing I didn't comment on, she's hyperglobulinemic, probably polyclonal from the inflammatory process. I don't think this is a dysproteinemic disorder.
Good. And I suppose, in the lupus, I always kind of don't always put this top of my list, but when we talk about minimal change and lupus kind of going together, we have that elusive podocytopathy lesion, which I know you're well aware of. And, that's always a mixture. But, typically those patients will have features of both background lupus mesangial disease and diffuse foot process effacement. So we'll have to see if that is relevant. Oh, but you're right. I mean, this could be the lupus, which I totally agree with you. I mean, I think she has lupus. It doesn't, she's a woman, a Hispanic woman with these symptoms. I have to agree. And I just make the point that we don't be too pedantic in looking at how we diagnose lupus and go by, 2 from this column and 3 from this column with the ARA criteria, which really weren't meant to be all encompassing and all defining. So I totally agree with you. In fact, I appreciate your absolute confidence in this. Even if you're wrong, I love the confidence, because I think that's the way I would look at this, that she does have lupus. So, Dr. Corbett, what do you have to add to this differential diagnosis?
Not a great deal. I mean, he really covered it quite nicely. I kind of very quickly had coned it down to membranous and lupus podocytopathy, or minimal change disease associated with lupus. The whole issue of the microscopic hematuria, even with idiopathic, or primary minimal change disease, at least in adults, we found that 25% of them will have microscopic hematuria. And even with FSGS, 50%, it's not like 100%, but they'll have microscopic hematuria. And I know this whole nephrotic thing it continues to really bother medical students as much as anybody, trying to understand that. And I was always trying to make the point that was something done clinically. It was a clinical descriptor, really, if you will, based on laboratory studies and physical findings, and it preceded histology. I think it kind of started at dated back to the time of Bright, if you will. And then when histology got brought into the mix, then all of a sudden we saw how you could have these inflammatory lesions coexisting with the non-inflammatory, if you will. But I think he covered it. The question is, which one is it membranous or is it the podocytopathy? And I think as he also brought up ALEC2, I mean, they generally don't have this kind of explosive nephrotic syndrome. It's much more minimal proteinuria and progressive renal disease with interstitial findings of amyloid. The way this thing kind of exploded, which is the way, at least the way Bill has kind of shown us by the fact that the albumin was normal 9 months ago, and then 3 months ago it was down to 3. That's pretty relatively rapid in onset. It goes along to me a lot more with minimal change disease or lupus podocytopathy. And I assume we'll see, as you alluded to, Roger, mesangial deposits to go along with that diagnosis. But membranous is definitely a possibility as well. I think the thing that the enigma to me is, and it's kind of off the beaten path, if you will, is all these thrombotic events. If she'd have been nephrotic the whole time, we'd have just said, well, she was predisposed because she was nephrotic and they just didn't treat her with anticoagulation. But the reality of it is, at least the way Bill's spelling it out here, is that the nephrotic syndrome all came on later in the whole process. And I just find it interesting that the hypercoagulable workup, because I thought as I started reading this is going to be somebody with antiphospholipid antibody syndrome. And then what are the lesions with that? And some of those can have membranous coexisting with it. But the way it started and the way it ended up are completely two different things. So I would still love to have an answer as to why this woman has such a thrombotic predisposition. And I just have to trust that what Bill's saying is the beta 2 glycoprotein 1 and all the others were completely negative, as he alluded to. So I'm just going to come back around and just say, I'm going to put number 1 as podocytopathy or minimal change disease, and number 2, lupus-associated membranous.
Podocytopathy came from this number of papers way back where they described, the coexistence of minimal change disease in patients with lupus. And then, people kind of put 2 and 2 together, that it seemed to be a little more common than just coincidence. And that most of these patients did have some other findings. They shouldn't have lupus, but they had background mesangial disease. And that this may not be an independent process. It might be its own pathophysiology of a podocyte injury with diffuse foot process effacement. What I don't know is where those, I know that they're very nephrotic and it all kind of looked like minimal change disease in lupus. What I don't know is if they were that actually explosive that we typically see in classic minimal change disease. Steve, do you remember, or does any?
No, I'd have to go back to look at, Steve Kraft did the article from here. And then prior to that was, I think Jerry Appel's group had an article out. And I don't recall as well, but I know many of these cases, even Carl Nolf years and years ago had a case of what they called FSGS associated with lupus, which probably was a podocytopathy as well. And it came on relatively suddenly, but I don't remember specifically how rapidly these things came on.
Steve, did we coin the term?
One of the big conundrums though in all of these papers was, just to throw this out there, a lot of these patients with lupus were taking NSAIDs. And I think that was one of the issues early on, was was it lupus or was it the fact that they were getting NSAIDs for their arthralgias and stuff. And I think we had a number, and others that had a number of patients that, while they might have been on them initially, had come off of them or weren't on them ever. But that was one of the kind of early conundrums about, was it really a lupus issue or was it they were on NSAIDs and that was what was causing it?
Yeah. Steve, did we coin the phrase lupus podocytopathy? I don't remember.
Well, the proverbial we would have been Ed.
That's we. I take credit for everything Ed does, so you know that.
Well, I know
Everybody
you do,
knows that.
but that's you. I think
Yeah, so we as it did, yeah. Dr. Lewis,
I think
you
Ed
people.
did, and I think I'm just trying to remember who wrote an editorial not that long ago and gave him credit. I don't know if it was Brad Rovin or somebody, but they did give him credit for it. But I thought Ed had been the one that came up with that.
I mean, it's a great term because it really gets you to probably, more of the pathophysiology and not just minimal change. I mean, it actually, and we're probably going to see it in more diseases, and as we understand pathophysiology even more. The really interesting thing that this case, if there's a clue, is the explosive nature and the degree of nephrosis and the explosive nature, which is what I think we're kind of heading towards, maybe minimal change. I mean, membranous, lupus membranous, I don't know, these patients, not that I have that much experience, but they seem to creep up on me a little bit more than just being that suddenly nephrotic. And so I think there might be some money there.
What I think is neat about all of this is kind of the Hell's Kitchen in immunology that's going on in these lupus patients. I mean, you got those patients that have membranous that have these, what they used to call high affinity antibodies, which would be IgG4, low affinity, so that the antibody antigens would dissociate and then reform in situ. And then the ones that get, that's usually IgG4, the ones that then get the DPGN had what they were calling high affinity antibodies, like IgG1 and 3. And then you've got those that get antiphospholipid antibodies. And then you've got something that might be causing vasculitis that's not necessarily ANCA. And then you got this that's affecting the podocyte. I mean, there's so much going on with these people. It's not just an immune complex disease all the time.
Yeah, and Dr. Rubin brought up, you know, the anti-exostocin antibody that's been seen in a lot of these autoimmune diseases, and that's certainly what I think we would predict if this is a membranous. We don't have the ability to stain for that. I think shortly we will, or we'll start sending it out, and maybe maybe that's here. I don't know, because I really don't know yet. But the point is, what I'm trying to make is that we have for PLA2R positive, we've got a blood test for that. And I believe there's a blood test for thrombospondin antibodies. I'm not sure about that, but I don't think there's a blood test for exostocin. I think it's only been demonstrated on the kidney. Do you, Mario, is that right?
No, I think I stand corrected. It's only in the biopsy that you can stain for it.
Yeah, yeah. Well, yeah. So I mean, maybe someday we'll have a membranous panel, and we'll check for, you know, all these antibodies. But it is interesting that some you can find in the serum and some you can't find in the serum. I don't know about NEL2, and I had a table somewhere. I can't remember them all, but I know certainly thrombospondin and we use PLA2R clinically, not only to diagnose and not biopsy some people, but use it as a therapeutic response as well. So it'll be fun to see, as you say, all these biomarkers as the future comes on. I think it's a very exciting time that, you know, that we're in the renaissance of this. It's really going to be fun looking back, and it's fun being part of it right now. Bill, did you have something you wanted to say? No, okay. I think it's, unless anybody else had anything, let's spin the wheel.
The only other thing, Roger, when you go for the wheel, is it was brought up the COVID vaccination. And interestingly, there was a recent paper by the group at Columbia where they review their experience and others. It's a nice systematic review of glomerular diseases in association with the COVID vaccine. Most of the described cases have taken place within 2 weeks. You know, in this particular case was 4 weeks later, so who knows? With this COVID story, anything is possible, I guess.
No, I think that's a really good point. It does keep coming up in the chat board, and I think it's something you cannot ignore, because the number one lesion that has shown up is a minimal change disease, and it comes very quickly. And some of these are relapses, and some of these are de novo cases. The second most common is IgA. She is Hispanic. IgA, that this nephrotic would be highly unusual. But, you know, I mean, as long as we're giving a complete, I suppose we could throw that in there. We could say a COVID-related IgA, but I don't know that you could, you know, that nephrotic would be very, very unusual. But, you know, that's why we have these cases, because sometimes things don't always make sense, and that's why we do biopsies. So let's get to the great wheel.
We got to do something about the wheel. It's getting too much reflection from the lights.
It'll have to get its own studio.
Yeah, we have to get that kind of that glass that doesn't, you know, reflect.
Awesome, are you here today?
Yes, he is. Awesome, give me a second here. I'm going to give you control and allow you to unmute yourself.
Awesome, the wheel's been very fond of you lately. It used to be Faraz, now it's the awesome wheel. Awesome's one of our second-year fellows, audience.
He did read a biopsy in front of our local NKF, so this should be routine for him now.
And he got
Awesome.
an A plus
Can you
from
hear
the he got an A plus from the visiting renal pathologist. So the pressure's on, Awesome.
Okay, Awesome. I'm going to share the screen and give you control. Just remember, you know, click, and there's a delay usually with the slides, but if you're having trouble, I'll take control of the slides. Okay, sounds good. Give me a second here. All right, go ahead and click on the screen. Yep, you're controlling my screen. Yep.
All right, so we have a low power trichrome stain to begin with. I do see at least 3 cores of renal cortices. There is some tissue from the renal medulla as well. We are primarily looking for evidence of chronicity here with a bluish material, which I don't really see a lot. I mean, I do see a few gloms here, but the tubules look back to back. There is not much evidence of chronicity, maybe about 10 to 15% at the most.
Great. Yeah, I agree with that. That's what I said.
So we have an H&E stain here. This is probably a, we are looking at a glom towards the left side. Here you can see the urinary space just to orient myself. And on the upper right side, you can see the tubules. So in terms of the glom, we do see the glomerular capillaries seem to be pretty patent to me. I don't really see any obvious crescent here. There are probably some focal areas of increased mesangial expansion here, as well as at this point. I do see some focal areas of increased mesangial cellularity as well, with more than 3 cells probably here at this point. But overall, the glom looks fine without any evidence of crescent. In terms of the tubules, tubules look healthy. I don't really see any evidence of ATN. I'm not sure what is this material here in this tubule, maybe some sloughing off here.
Yeah, there may be a little bit. We'll have to see on the PAS stain if there's a brush border or not, or that can just be proteinaceous material. But
Okay,
I agree with you. Overall, the tubules look pretty good.
sounds good. Another H&E stain. Here again, we see a glom in the middle. The tubules, the glomerular capillaries, again, look pretty patent to me. No obvious evidence of any crescent here. Again, there are certain areas, for example, this point, where do I see some mesangial expansion? So again, focal areas of mesangial expansion. The urinary space seems good and clear to me. The tubules, again, this is probably a distal convoluted tubule, I would say.
What about the material inside? What do you think that is?
Again, well, this might be red blood cells.
Yeah, those are RBC casts.
RBC casts. Okay, and I see more than one tubules having the RBC casts there.
Yep. And then the other thing I would point out is you have an arterial at 9 o'clock up the glomerulus that shows no thrombosis, widely patent, just below your arrow a little bit. If you go down a little bit.
Maybe this is a little nephrotic and nephritic.
Okay.
Yeah, I think Bill's point is right. I mean, red cell casts, that's not just a few red cells.
Mhm.
Mm.
All right. So the next one we have PAS stain. Sorry.
Oh, too far.
I'm not doing it. Okay. So PAS stain, again, probably a medium magnification. Here we see again another glom in the middle. Here we can see the GBMs here, which look pretty healthy to me. There is some areas of probably increased GBM thickness around this point. Again, the glomerular capillary tuft looks pretty patent. Here around the site, there is some expansion here, but maybe it's just the, yeah, I'm not sure if this is significant because it's just close to the hilum.
Yeah, the hilum's down there at 6 o'clock, but like right in the middle of the glomerulus, I see some mesangial hypercellularity and a little bit of mesangial expansion, like we said. Yeah.
Okay.
Yeah.
Sounds good. Yeah, it's pretty much similar to what we saw in the previous
Yeah.
slide. Here, as we can see, the GBMs much clearly on the PAS stain. I do see even here some sloughing off, and again, there is some proteinaceous material here as well. And along these two, again, probably these are again the red blood cell casts, if I'm not mistaken here.
Yeah, those are probably red cell casts. And then down at the bottom right, there's an artery that looks wide open, and yeah, there's an arterial there, and over to the far right is a large
Okay.
interlobular that looks open and good, no thrombi.
Okay.
Just a little delay. So here I'll advance the slide.
Okay. Can you go back one slide, Pravir? There you go. Yep. So here we have the Jones stain or silver stain, primarily looking for any ruptures, holes.
This will be your Jones stain right here.
Yeah.
What is that? Yeah.
All right. So yeah, so we're looking for any split spikes, holes, or ruptures. Again, the glomerular capillary tuft looks pretty open to me. I don't really see any obvious holes or spikes or ruptures here. Again, there are focal areas of mesangial expansion here, probably around this side.
Yeah,
And-
I agree that the glomerular basement membranes look smooth. I don't see any obvious spikes or holes.
Okay.
David, I see
Yeah.
some breaks down there. I think it's probably artifact, but
Yeah.
right there. Is that just artifact?
Yeah, I think that's just artifact. Yeah.
I mean, it's only relevant in the context of red blood cell cast, nothing else really clinically, but there are some breaks there. But there's nothing else inflammatory to make you believe that's real, and no fibrin or anything else. So,
Right. Yeah.
Okay.
I'll advance the slide.
Okay. All right. So here we have the immunofluorescence. We can see diffuse granular, pattern here with IgG positive. So I think it's along the. We do see some in the mesangium as well as in the capillary walls as well.
Yeah, predominantly capillary wall.
Okay.
Yeah.
Yeah, it's amazing how much the mesangium doesn't seem to be that involved, right?
Right. Yeah. And this was only positive for IgG. IgM and IgA were negative. It was not full house, and C1q was negative as well.
Yeah.
Oh, man.
So then okay, yeah, let's see the next slide.
All right, so we have the EM here. Again, just to orient ourselves, this is probably the blood space.
Yes.
Here is another capillary. So we are looking at if I track down the GBM, there are certain points where the GBM might be a little bit more thick than what I would expect it to be. Here, maybe I'm not sure if this is some degree of a subepithelial deposits here around the side.
Yes. Yeah. Those are.
Okay.
Especially in that loop above you, over to the left a little bit. Yeah, and down to the right where you were. Yeah, right there. Yeah, there they are.
Yeah. Other than that, in the mesangium, I really don't see any. Again, even in the EM, I don't really see a lot of deposits in the mesangium.
Yeah, well, the mesangium's over in the bottom right. Yeah, down there. Yeah. So there's no obvious deposits there.
Right.
Yeah.
And then
how about foot process effacement? What do you think?
Yeah, I see there is significant foot process effacement, especially around this spot. So I think this is diffuse foot process effacement as well.
Yep.
All right, another slice of the EM. Again, now I think, oh, sorry. Can you go back one slide, Praveer?
Second, I think you're on a delay for some reason. It should pop up on your screen again.
Okay.
Yeah. Can you see it?
Yeah, I can see this slide. I thought there was another one in between, but I can just go about this one.
Yeah.
So here, this slide is again pretty obvious. I can see a lot of deposits there in the GBM, especially around this site. Again, looks like it's more like subepithelial deposits.
Yes, yeah, they look like, new fresh deposits. We don't see a lot of basement membrane reaction yet.
I see.
So that would explain the lack of spikes and holes on the silver stain.
I see.
Yeah.
And again, I think the foot process effacement is pretty obvious here. That's pretty diffuse as well in this slide.
Yeah. And
So
then do you see a mesangial area? Can you circle that? Do you see any deposits there? Yeah.
This would be mesangial area.
No, why don't you, that's like go down. There's a better one right in the center of the screen. Yeah, right there. There's a mesangial area.
Okay.
Yeah.
I see. Yeah, I don't really see a lot of deposits there.
Correct.
So there's several questions in the chat. Someone was asking about hump-like deposits, and some of those deposits are pretty big, but typically, David, you can comment on it. But typically, when you see humps, they're sitting a little higher and they're more spread out, and
Yeah.
you would just call these big subepithelial deposits, and you wouldn't classify them as hump-like, correct?
Yeah. I mean, the hump like it's in the setting of post-infectious glomerulonephritis.
yeah,
And usually one capillary has one large hump deposit, and you could see these have at least a dozen deposits for each capillary. So these are more numerous.
And people asking about PLA2R and IgG subclass, so we don't have that. So we're just going to have to go on.
Yeah.
All right. Pravir, can you proceed to the next slide? Yeah. Okay. Again, just to orient ourselves, this is the vascular space. Here there is probably another vascular space with a red blood cell here. Again, I can see some focal deposits here. Again, more so probably look like, as Dr. Sembelik said, more like fresh deposits, more towards the subepithelial aspect of the GBM. I don't really see any endothelial deposits here either. The nucleus looks pretty good.
Yeah, that's a good note. Yeah, no subendothelial deposits, and I did not see any TRIs either in the endothelium.
I see. And again, here I can see the foot processes are effaced here in the slide too.
Yeah. Yes, so just another image showing again the diffuse nature of the subepithelial deposits.
Yeah, I can just kind of point towards them. I think that's pretty obvious here.
Yeah, yep.
So, Asim, what's your histopathologic diagnosis?
So histopathological diagnosis here would be, these deposits in the membrane that kind of goes along with the membranous nephropathy, I would say.
And
it could be in the setting of lupus, although we should have seen kind of, full house pattern there, which is kind of interesting that we are only seeing IgG positivity here in the absence of other immune markers.
it's a good point, but do remember that on light there was mesangial expansion, there was mesangial hypercellularity, and there was some mesangial deposits, both on EM and immunofluorescence. So, if you want to try to make that distinction, which isn't 100% anyway, you're about 50% there. It's not everything you'd like to see with lupus membranous, but it's not there's not absent either of everything.
There were no tubular reticular structures, right?
Right.
Yeah, he said none. Yeah.
And then no subendothelial deposits either?
No.
Okay.
And just to correct you a little bit, Roger, there really wasn't that much mesangial. We didn't see really any on the
Right.
EM, and the immunofluorescence was sort of striking for the fact that it was almost solely based membrane. Now, on light, you're right. We did have a little bit of hypercellularity, but most of it was really an absence of mesangial.
David, I thought we pointed out a mesangial deposit on the EM. No?
No, we
Okay.
didn't see any mesangial deposits.
I'm sorry. I thought, okay, my bad.
And
So
photocytopathy, maybe just the lupus photocytopathy, as we were talking about, that's probably another striking feature on the biopsy.
yeah, the foot process effacement was what percent?
It was diffuse greater than 90%.
Okay, so we could talk about the role of foot process effacement and whether or not you can have podocytopathy on top of membranous, but clearly there was a very bad membranous. I think it's, well, okay, Bill, I'll just finish my sentence. How explosive this was, and yet how those deposits didn't look like they came on in a day. So Bill, go ahead.
Yeah, so I'll just touch that real quick, and then we can come back to any other points you want to make. But we did look at basically what's the reason for proteinuria in patients who have membranous lupus nephritis, and we took all of our patients who had pure membranous and really measured out kind of what their immunofluorescence was and also what their foot process width was and foot process effacement. And what we found was that the subnephrotics really did not have that much foot process effacement, and the nephrotic patients did. And so this kind of started us along the path of really being descriptive in the hopeful future of classifications to try to include a lot of these things in the classification. You could have a podocytopathy alone, which would be the minimal change like lesion, but you could also have a diffuse proliferative with foot process effacement and be nephrotic. You certainly can have a membranous patient who has foot process effacement, and they're more likely to be nephrotic as well. And so there may be a little bit of an overlap, but there was certainly a trend here and a correlation to foot process width and effacement with nephrotic syndrome. And so we kind of think that this podocytopathy can exist in all of the classes and probably should hopefully be commented on in the future.
And I like that because, we've talked about this before, and this is all speculation until we really understand the true pathophysiologies of these. But we see many lesions in lupus, and who's to say that they all have the same pathophysiology, that the pauciommunes may have one pathophysiology similar to what happens in idiopathic vasculitis. Membranous, there's a very good chance it's an antibody, and soon hopefully we'll be staining for exostocin, get a better idea of that. And the DPGN could be more of a circulating immune complex pathophysiology, and the podocytopathy yet another. And who's to say that there isn't four different, for each of these lesions have their own, because you can see any permutation, it seems to be, of just about any of these. And like I said, we don't know that, it's speculation, and it's interesting to talk about, but we'll just have to see. Dr. Rubin, are you surprised, or what are your comments after looking at the pathology and some of our comments?
I think that what makes sense is what Steve brought up. I mean, basically the explosive nature suggests there is superimposed podocytopathy, which is what we see. I would have expected a more flooded immunofluorescence, but again, you may not see it, not all the time. You will see a full house, as it was mentioned. The other thing is that I heard the other day a superb lecture by one of the associates of Helmut Renke, and I forget her name, David probably knows her. She emphasizes the fact that we keep calling foot process effacement when in fact it's detachment. It's not effacement. And she mentioned the pathophys, so stay tuned for that change coming up. Fascinating case. Now, was a PLA2R staining done on this biopsy?
Well, let's go to the next slide.
Okay.
Yeah, when I was called by the rheumatologist, Dr. Rubin, I'd already put my top 10, let alone top 5, as being either lupus membranous or podocytopathy. So when it came back to be not a full house, not much mesangial, no TRIs, I got a little concerned, and then I go ahead and I asked David to run the PLA2R stain.
And everybody remembers that whenever Dr. Whittier has top 10, he's always wrong. So
exactly, and that's not the only time I'm wrong. Even when I think it's only one, I'm often wrong. So let's not limit it to just that.
So could you advance the slide? Well, I can read this for you, but our audience is not stupid. They're very bright. They've been bringing this up all along. What's the PLA2R? What's the PLA2R? What's the PLA2R? Bill, did you order a PLA2R antibody? Obviously, this is quite positive. Bill, did you order one in the serum?
Certainly not before the biopsy, because again, my pre-test probability was so right. And I was so confident in it that I was wrong. So, but once we saw this come back, I did check it, and it was 282 in the serum.
So that's quite elevated. So before we hand it back to you to discuss this condition, is this lupus? Is this idiopathic membranous? Is it lupus with membranous? Let me just ask Dr. Rubin, since you've been in control today so nicely, and thank you for being such a good sport. What do you think is going on? And do you think this is one disease, two diseases, and how would you treat this patient?
Well, I think I'm going to take the side of the splitters this time. I think that most likely this represents a dual problem. I think she has lupus with a superimposed primary membranous. What it doesn't make sense is, as you mentioned, the presentation of membranous is not so explosive. That's not what we usually see. But you know, as my friend Hippocrates said, there are no diseases but sick people. So I guess it's possible. So I will imply that this is a dual process.
And so with that in mind, how would you treat this patient? If you
I
think it's a
think,
dual process and the main lesion is PLA2R positive, what would you treat her with?
Well, you know, she's obese, and therefore I would use low-dose steroids and, of course, rituximab.
Okay. Anybody feel differently? All right. Well, Bill, why don't you walk us through this one disease, two disease, splitter, lumper, Occam, Hickam.
Excellent. Pravir, can I share?
Yep, go for it.
Okay, thanks. So yes. Hold on, it disappeared, Pravir.
Oh, you want me to show the slides?
Yeah, that'd be fine.
Yeah.
That's great. Yeah, thank you. So yeah, I mean, really, that was the discussion. I was pretty surprised that the PLA2R was positive. I was sort of expecting it to be exostosine, and we know that exostosine is, I wouldn't say we know it's the antigen associated with membranous lupus, but because here in this study, it showed that about 32% of the cases of what they thought was pure membranous lupus nephritis were exostosine positive. And some are still negative. And so there's overlap. And like you said, Roger, hopefully we do have a panel at some point and we're able to even stop calling it primary and secondary and just calling it by the antigen. You know, this is PLA2R membranous, this is thrombospondin membranous, this is exostosine membranous, and we'll have hopefully even treatment data eventually if we could classify this in the right way. But in this cohort, about 30% of their patients were exostosine positive, and it actually had predictive value as well. With the ones that were exostosine positive were a little bit less likely to respond. You can go to the next slide. So we don't have exostosine available at Rush, and so we're not quite sure if this happened to be somebody with, I wasn't sure if there was exostosine there, but what we did come back with is that it was PLA2R positive. Now, does that mean it's PLA2R positive membranous in a patient with lupus? Or does it mean that the PLA2R positive is really something because of lupus? And so this cohort of patients was evaluated further in 37 patients out of, I think they had about 250 patients who had lupus, and 37 of them had membranous lupus nephritis. And about 20% of them had PLA2R positive in their cohort of what they were calling membranous lupus nephritis. And so there is some overlap here.
Bill, this is serum or tissue?
Actually, it was in both. So it was in, again, it was only 37 patients, and about 7 of them or 20% had positive. And I think 5 of the 7 also had positive in the serum. So,
Got it.
So it did correlate. And so really we're left with that. We don't really know. We don't have an answer right now. We do have the fact that it is membranous. And I think that knowing that it was PLA2R made me sort of want to treat it like the PLA2R membranous. But honestly, those patients who have lupus membranous can be treated the same way. The part about the podocytopathy did make me want to lean in and do a little bit more of the higher dose of steroids than 20 milligrams. I really, in my mind, was thinking about giving her 60 milligrams. But just like Dr. Rubin said, you know, she is obese, and right now she's already on anticoagulation. And so and she has normal renal function. So I thought that the main complication from the nephrotic syndrome was already going to be covered. And so because she was obese, what I elected to do is just give her Rituxan alone. And I didn't give her any steroids. And I didn't add on Cellcept or anything, kind of like they would have done in the Rituxa loop study. So I really treated her like a primary membranous and Rituxan alone. Now, she did get IV Solu-Medrol with the Rituxan infusions, but I gave 1 gram 2 weeks apart. And it's been about 3 months, and her PLA2R antibody went from 282 down to 1. And her proteinuria is at 800 milligrams right now. She's completely off diuretics. She's just completely responded a lot faster than even many of my membranous patients have responded. So she came on very quickly, and she responded very quickly, and she responded without steroids.
That's really interesting because that is very fast compared to, you know, the median time in the Mentor trial. And
And
I
it
don't know if
might
is.
just be because we got to her so early. Those deposits were very fresh. We knew her disease state was so fresh. I mean, her presentation of PE might have actually saved her kidney, because that's what brought her into the hospital, and that, you know, we were able to get a diagnosis very, very quickly. And
Yeah,
I
but
think that,
typically, you know, it's not unusual after 6 months for your PLA2R to go in only in half. I mean, and that's in 6 months. And then by 9 months, the proteinuria sometimes goes down. And that's just, there's no answer here. It's just, that's a remarkably fast response, and it's good for her and it's good for you. Obviously, that's a great drug, unless it was a spontaneous remission, which is unlikely with that level of PLA2R. And it just seems, you know, pretty unlikely that's what's happening.
Bill, in the absence of exostosin staining, does the characterization of the IgG isotype help you in differentiating primary versus lupus membranous?
no, I don't believe in lupus that it does. I know that there's been some hints in the past of a hepatitis related membranous being maybe IgG4 versus IgG1. I think Ohio State published that, or at least I saw a poster on it once, but I haven't seen the IgG subclass be linked to lupus. But I would also defer, Steve or Roger, do you know the answer to
Well,
that?
I think it's, I mean, if this were pure PLA2R, I think IgG4 would be predominant. And if not, I think it would be IgG3. But again, you know, we don't have that. We're working on, you know, I was just talking to Dave this week about the possibility of doing some more send outs on some of these things. I don't think it's going to change the case here. And those are things that are difficult to do. It's easy for a place like Mayo Clinic or Arcana to do that because they'll do it 10 times a day. But for us to have reagents that are only going to be used once a month is a little impractical. But we're working on, you know, being able to get a little bit better idea in some of these. It'd be interesting. Maybe exostosin would also stain positive here. You know, you never know.
I thought Ed, I don't know if it was Jimmy, years and years ago, when they looked at this in lupus membranous, found that it was IgG4 as well. Whereas in DPGN, diffuse proliferative lupus, it's IgG1 and 3, because they're the ones that activate complement more, you know, I guess, actively. But I thought they had even published that it was IgG4 in lupus membranous.
David, do you want to be the tiebreaker, or do you know?
I'm gonna
Defer.
defer. Yeah.
Yeah. Yeah, I'm not sure. I know that many of the secondaries are IgG3, and that's one way to tell, but I don't know about, I'm sure you'll be able to find that for us and let us know, but that's a good point. I mean, regardless, we're kind of stuck with, you know, is this one disease or two? And maybe it doesn't matter maybe it doesn't matter therapeutically, and obviously you hit a home run with your therapy. But it would be nice to know, because it keeps coming up in the chat. Is this one or two? And, you know, maybe we'll never know, or at least we'll never know now. And the COVID vaccine, it could have played a role. It's a little late. You said the COVID was a few months ago, Bill, or was it 1 month ago?
It was
vaccine.
4 months ago, but 3 months ago, she had not been a 3.
Okay, so yeah, I mean, that's a little late too, but you know, we're still learning everything about the vaccine, and that the vaccine for IgA and the vaccine causing minimal change, those are different diseases too than membranous, which kind of sneaks up on you. So who knows? Maybe she got the vaccine and started developing this, and you know, so again, who knows? A lot of people are getting the vaccine, so it's hard to always blame everything. It's easy to blame everything on the vaccine because most people, at least in Illinois, are being vaccinated. Any other comments?
I think there's one more question. If the immunofluorescence was a full house, would that have changed management? I don't. Oh, go ahead, Bill.
No, I'm sorry, Pravir.
Oh no, I don't think. I mean, you still had we didn't see any type of segmental necrosis or anything like that, or any type of really active lesions in the biopsy. Primarily, I mean, you would treat this, I guess, steroids maybe, as was mentioned, but with all the other factors in play with her, BMI and everything, I don't think the immunofluorescence would have changed anything. But then you would definitely consider the lupus podocytopathy a little more, and kind of two different processes. And the other part I want to say, I believe the exotosin ones, they present with more proteinuria. So it's definitely possible. I mean, maybe she has both. I don't know, but I thought they present with a little more proteinuria than the ones that are negative. But they also have less. The exotosin positive ones also have less tubular interstitial disease and kind of chronicity.
And if it was lupus, if it was a full house, and we had those classic findings, I have to say that pure Rituxan alone, without steroids, without CellCept, hasn't really been evaluated that well in lupus. I mean, I think there's one case series of 13 patients. Even the Rituxaloop study, which we think about the 50 consecutive patients from Liz Lightstone, was using CellCept in addition to Rituxan. And of course, the Lunar study was Rituxan with add-on to CellCept. So we don't, if it was really lupus, would I've actually added CellCept in addition? Or maybe added some steroids in addition? I may have. I got away with it, and I'm glad I did because I spared this woman steroids, but it just hasn't really been evaluated.
So I can tell you right now, here's the article. It was differential characteristics of immune-bound antibodies in diffuse proliferative and membranous forms of lupus. And sure enough, in diffuse proliferative, it was IgG1 and 3, and in membranous, what they found was IgG4.
Lupus membranous IgG4.
Yeah. I mean, I
Yeah,
can
that's
give you,
good. That's interesting. That's great because that's sorry.
it was in the
everybody.
Clinical Immunology and Immunopathology Journal. It was back in 1983 that he and Jimmy did this with Mel.
Before most of our audience was born, but great science. That great science doesn't get old. So Bill says he would have still used Rituxan and possibly added something. Who knows? But for those of you who don't know Bill well, his nickname is Rituxabill. So there's no question that Rituxan wasn't going to be part of the therapy. It's just whether or not he would have added a little bit of steroid, more steroid, or MMF. And I think let's wrap it up right there. Thank you, everybody. That was a great case. I, again, played a little game with the holding off on the PLA2R, but I didn't fool the audience at all, which I rarely do because they're so smart. But I thought it'd be fun to present it that way. And it led to a better discussion. So thanks for all playing along with me. Again, today's CME activity code is 483327. This is being recorded. It'll be available on our YouTube channel shortly. We'll see everybody next week, and thanks for coming.